Heidi Miller and I work over in Sacramento, California at UC Davis Eye Center. Thank you so much for having me here today for Class 2020. Wish I could have been there with everyone in person, but I hope you enjoy learning a little bit more about pediatric contact lenses in your practice. I do have a few disclosures. I am an educational consultant for Valley Contacts. I do some speaking for Bausch & Lomb and Alcon. But let's get into a little overview on what we're going to talk about today. We're going to go over indications for pediatric contact lenses in your office, contact lens options available for your pediatric patients, fitting techniques, and go over a few patient cases. Some indications for pediatric patients, and a lot of times we primarily think of our population as being aphakics, but there's a lot of other patients that we can fit into contact lenses in our pediatric population. Aside from aphakia, we have our high myopic patients, we have our high hyperopic patients, ocular surface disease, which is not something we commonly think, but when we go through a patient case, you'll see that this is an opportunity for a pediatric patient as well. So our patients that have irregular astigmatism, whether that be from trauma or some sort of surgery or corneal dystrophy, photophobia, and we'll go a little bit more into that. Also, amblyopia therapy. A lot of times we don't think about contact lenses for that type of option, such as patching, but that can be a very viable option for pediatric patients when you're struggling with patch therapy. Nystagmus patients have been shown to do a little bit better with contact lenses, especially GP lenses, and obviously our myopia control. When we talk about amblyopia, let's go through a few of the numbers really quick. It's really important to try to prevent amblyopia because with amblyopia, it is responsible for more vision loss in the patient population less than 45 years old than any other causes of vision loss. So this is a huge area where we want to make sure we're catching this early in our pediatric patients and addressing it appropriately. Amblyopia currently in North America is at 2.5%. Risk factors for amblyopia. We've got our deprivational amblyopia, and these are situations where we're getting no visual input to the back of the eye. Something is occluding that's causing that visual input to be obstructed. This can be cataracts, corneal opacities, ptosis, anything that we can think of that would be completely obscuring the eye and not allowing visual input. We also need to think about our strabismus patients, and this is why it's really important to see our children at early ages. If we can catch ocular deviations early that can be leading to amblyopia, we can address them, treat them, maybe have surgical intervention as needed. Refractive amblyopia is caused from either really high hyperopia, high myopia, or high amounts of astigmatism. At least 2 diopters of anisotropia between the two eyes can lead to refractive amblyopia. And when we're talking about binocular type of refractive errors, or bilateral, not binocular, bilateral refractive errors, bilateral hyperopia is at a greater risk because the refractive error does not need to be as high to have that amyloidogenic factor. Meridional anisometropia is when there's high astigmatism, and if you have oblique astigmatism, you're even at a higher risk there as well. Benefits of contact lenses over spectacles. A lot of times, we apply these applications to our adult patients and we tell them all the great reasons of why they should wear contact lenses, but we forget about these same type of applications for pediatrics. And I don't know if it's related to the idea that we think it's going to take more chair time or it's going to be a little bit more difficult because it's a child, but really in studies that they've shown, it doesn't take too much more chair time to fit a child versus an adult. And so we should really apply some of these benefits for contact lenses when we're thinking about our pediatric patients. For instance, field of view, get more peripheral vision when you don't have a frame obscuring that area. Also, decreased aberrations because the contact lens is now on the eye. We can prevent anisoconia from having magnification differences between the two eyes. And with increased magnification for myopes, you'll often see that they have better vision when they're wearing contact lenses. So you may have had a patient where they're a -10 and they're about 20/30, give or take some guesses, but then you put them in contact lenses and they're 20/20. And really a lot of that just comes from the magnification difference where now they're seeing a lot clearer because things are not as magnified as they are in their glasses. You avoid induced prism when you're wearing contact lenses, and you don't have to worry about keeping a frame in place. So, glasses sliding down a child's face, not sure if they're getting full vision, if they're losing them at school, or if they're even wearing them at all. So with contact lenses, a little bit more reliability that they'll actually be wearing them all day. When we look at anisoconia, this is where we're talking about magnification differences between refractive errors in two eyes. And this is one of the highest risks in refractive anisometropia, because if you have too big of a difference between the two eyes, the better seeing eye is going to be favored and take over. And when we think about putting contacts on the eyes and eliminating those magnification differences, what it can do is reduce asthenopia, and it can also help improve binocularity, because now we don't have those differences in magnification, so we're promoting fusion and better binocularity in these kids. Relative spectacle magnification disparity, what we're looking at here is basically that, again, as that disparity between the two eyes becomes greater, we start to have a harder time tolerating those glasses. And this even applies when someone gets cataract surgery and the difference between their two eyes is so great that they're now complaining of things like headaches, double vision. Same thing applies with our children. If their vision or if the refractive error in each eye is very different, we can expect there to be some difficulty with potential fusion, difficulty with tolerating that prescription, and we really want to be promoting binocular function at all costs if we can. So if there is too big of a difference between the two eyes, we could be impairing their binocular function. When we use an example of magnification effects in unilateral aphakia, you can imagine that a patient is having about a plus 32 contact lens in one eye. And if they were in glasses, that would be about 20-30% magnification difference between the two eyes. We put them in contacts, now it's about 8 to 12% magnification. So a huge improvement in those magnification differences, which is obviously going to help promote binocular fusion and help with all of these other issues that we were talking about with asthenopia. And once they eventually get an IOL, their vision in terms of magnification differences will be normal. Let's take a look at some contact lens options. Soft hydrogels are an option to treat pediatric patients. Some advantages with soft hydrogels are they're very comfortable and they're going to stay in place because they're a soft lens in the eye. Some disadvantages to think about are high cost. These lenses don't have as high of oxygen permeability as some other options. They can be difficult to handle because they are a little bit more flimsy, and they tear easily. They also are prone to having depositing on the surface, and with children, depositing is a big issue. So this being an issue there, you might have to replace the lenses more often, might have to take them out to clean them more. So that's something to keep in mind when you're making a selection for your pediatric patient. There's also a risk of infection and extended wear with soft hydrogels, and with any soft lens, you're not going to be able to mask corneal irregularities. Now, when we take a look at SilSoft, this is one of the most common lenses that we use for treating aphakic patients. It's a great lens for handling. I'm sure we've all handled one and noticed the button is very easy to hold on to. When you're putting the lens in and out, it's very easy to grab onto that button in the center of the lens. It's got good comfort for patients, stays in place, and it's approved for 30 days continuous wear. And I think that's really important. I don't usually promote extended wear or continuous wear with my patients in contact lenses. However, you will come to know when you're working with babies, sometimes they don't cooperate and sometimes they're fussy and it's hard to get the lens out. And so there may be times when a mom is just saying, I can't do this anymore today, and the baby's going to end up sleeping in that lens. And it's kind of peace of mind to know at least that this lens is approved for 30 days continuous wear, because that is potentially going to happen. And having this high oxygen permeability is amazing. It's really important. We're fitting babies and young children in these lenses, so oxygen permeability is very important. But with that comes more lipid deposition. When you have a really high oxygen lens, really wettable lens, it's hydrophobic, and so lipids start to build up on this lens. And that's one of the most common complaints that I hear from parents, is that they see that the lens is getting gunky and there's buildup on the lens over time. And I just reassure them that that's pretty common, especially with this type of lens. You're going to get some poor lens wetting as well with this lens. And again, with a soft lens, it's difficult to mask corneal irregularities because it's a soft lens. One of the biggest things that I think we don't think about with CLASS2020 initially when we're selecting this lens is that it is limited on parameters. And so it's really important from the get-go to think about that when you're fitting a patient, because you don't want to start with a lens and then hit a roadblock with parameter changes. So with CLASS2020, it is limited to 3 diopter steps when you're changing powers. The highest power it has is a plus 32. And so keep that in mind as well. And there's limited diameters and limited base curves. So if for whatever reason you encounter a patient where you've got the power you need, the base curve looks okay, but maybe the lens is dislocating or it's falling out a lot and you want to go a little bit bigger, that option may not be available. So just keep that in mind that there's some limited parameters with CLASS2020 and when you're fitting your patients. Another limitation that I have a lot with my patient population is high cost. So we're going to be changing this lens very often because there's rapid changes in corneal diameter, curvature, power, and there's also going to be a lot of lenses lost. It just happens, baby rubs their eye, mom doesn't know where the lens went, and at that point, by the time she finds it, it's shriveled up and dried out, and so they need a replacement lens. And CLASS2020 is an expensive lens. With insurance, reimbursement may not be great. And some insurances, depending on what insurances you do take, only cover X amount of lenses per year. So if this patient is prone to losing lenses and it starts becoming an out-of-pocket cost to the parents, it can get expensive. And then now we're facing a barrier with compliance. So keep that in mind as well. Each patient's going to be different. Each situation's going to be different. But if you're noticing kind of a pattern of lens loss, it may be a good idea to switch to something that has better cost. The other thing to keep in mind is that cost is a lot of times the driver for compliance and follow-ups. And so putting them in a lens that they're going to be successful with, and it's also not going to be a financial burden, may be a better idea too.
Miro 1 month delivers one of the highest levels of oxygen transmission. Available in sphere, toric and multifocal. Miro 1 month contact lenses from Menicon.
Prosthetic contact lenses are a great option for some of our pediatric patients. Some of the conditions that we would be treating for prosthetic contact lenses would be aniridia. So someone that needs an iris occluding lens to help prevent some of that light coming in, or just for cosmetic reasons as well. This would be a good option for that patient. Patients that are really photophobic. So our albinism patients are patients that have rod cone dystrophies, achromatopsia. These types of patients would be good in prosthetic contact lenses. And with achromatopsia, they prefer red, magentas, brown lenses that dampen the light stimulus to their eye. It helps dampen kind of the degree of photophobia that they're experiencing. Also, prosthetic lenses could be a great option for eliminating diplopia. And just as a patient example, I have about 3 patients that have had different nerve palsies that did not fully resolve. They became permanent. Prisms were not an option for them. And surgically, that wasn't an option either. So we ended up just doing an occlusive contact lens to block out one of the eye's visual input and eliminate the diplopia. For them, that was better than putting a patch over their glasses or wearing a patch full time. That felt like it drew a lot more attention than just having an occlusive contact lens that matched the color of their eye but was completely blacked out in the center. So that's another option as well. And that applies not just to adults, but also children. Different traumas that may occur for a patient to the eye in childhood years, they may end up needing a prosthetic lens to eliminate diplopia for that as well. The last one would be amblyopia therapy. And a lot of times we don't think about this. And some families will be concerned about risk factors with contact lenses and infection. And is it worth occluding the good seeing eye with a contact? What if something happens? But honestly, it comes down to patch therapy. And there's a lot of patients where the parents are struggling to get their kids to wear patches for the 2, 3 hours, 4 hours that they need to wear patches for. And they're trying atropine, but that's also not a successful option for them, whether it be cost or whether it be compliance. So contact lenses that are opaque or occlusive pupil lenses can be really advantageous in these situations. And with those type of patients, what you want to make sure you're doing is making sure that the opaque part of the pupil is large enough to occlude the pupil and some. So I always say add a few millimeters so that way if they're looking side to side, different gazes, they're still getting fully occluded. Otherwise, you might face that if you don't make that opaque pupil large enough, that they're still getting some sort of visual input in that seeing eye and not truly getting full effective patch therapy. The other option that you can do if a parent is concerned with cosmesis or maybe cost of an opaque pupil lens, they can do a high-powered plus or a high-powered minus lens. And what that will do is it essentially does the same thing as an opaque would, where it blurs out the eye, the good seeing eye, significantly enough that they become, they don't use that eye anymore and they'll use the other amblyopic eye. And so that can be an effective treatment as well. I tend to not have issues doing the opaque pupil, but you will decide kind of preference there and what you prefer doing. There's a lot of labs that do opaque pupils, so there's no real limitations there, but I know cost sometimes can be a factor or cosmesis can be a factor and replacement schedules and things like that. So you'll just have to kind of tailor towards the patient and the family and see what works best for them. The other contact lens option that we have for our patients is gas permeable contact lenses. And the advantages of GP lenses are high oxygen permeability. You're getting great tear exchange. They're really easy to handle. And you also get that enhanced optical quality. So if you've got someone with high astigmatism, if you've got someone with corneal irregularities for whatever reason, GP lenses can help mask those obstacles with the cornea to help provide good optical clarity. The other nice thing that I've noticed with GPs, especially with, infants, is that they're really easy to handle and with insertion and removal. Parents seem to have a lot of success on insertion and removal, just tucking that lens underneath the eyelid and then being able to easily see the edges of the lens has been really great with my patient population. Also, if you're dealing with really small, narrow lid fissures, that can be a lot easier than trying to get a flimsy, soft lens into the eye when the baby's not being cooperative. So really think about your GP lenses as an option for those pediatric patients because I've had a lot of great success with using GP lenses. There's also extensive parameters and designs that you can do with GP. So in terms of limitations on power or what size or curvature, you don't hit as many roadblocks with GPs because we've got a lot more flexibility with those parameters. You also have less bacterial and protein adherence, and they can be less expensive. So an example would be a patient that's losing a lens often. And mom's saying, every couple weeks we're losing a lens, we've got to replace it. The advantage with a GP lens is if that lens pops out in-house and mom's able to find that lens, we can clean it and then reuse that lens, put it in the eye. With a soft lens, we lose it. We don't find it for an hour. It's going to be dried out, and it's not going to really function the same. And oftentimes, because it's clear, it's just hard to find. Oftentimes, they don't find the lens at all. So that's another kind of nice thing with GPs, and to replace them, a lot less expensive for families. And they're aware that we're going to be replacing the lenses often in the beginning because of parameter changes, but it's nice to know that, they're easy to find, they're easy to clean, and it takes a little bit of that stress off if they lose it at home, if they happen to find it, that they can just, put it through a cycle of cleaning and still use that lens. So I've noticed that that's been really helpful, especially for the lens loss type of patients. Some disadvantages are that there could be some initial lens awareness. However, I don't fully count that as a disadvantage because with kids, they adapt really easily and you're going to be following up with them so often to make sure that the lens is fitting well. So usually that's not an issue. Kids are not usually as picky as adults are when it comes to that lens awareness and lens adaptation. We are prone, to lens dislocation and loss with GP lenses, especially if they rub their eye and the lid kind of hits the edge of the contact lens. It can fall out. And it does take a little bit of skill with fitting. And I wanted to put that in quotes because, as long as you can fit a GP and you have the knowledge on how to fit a GP, it's not any extra skill. It's just the idea that you've got to move quickly and be thinking a little bit on your toes because we're dealing with a child. So we've got a smaller window of cooperation. Some essentials for GP lens fitting. You don't have to have a handheld keratometer or autorefractor. However, if you do have something like that in office, that can be beneficial to get some starting point on Ks and starting point on refractive error. I say refractive error because you're going to want to do a diagnostic lens fitting, but for starting point on Ks, that could be helpful. You're always going to want to measure the corneal diameter. You'll want to use diagnostic gas permeable lenses. I have, depending on what I'm using it for, if it's an aphakic patient, an aphakic pediatric set. So they've already got the high plus powers that we're going to need. So we get a little bit closer to the endpoint quicker. As long as you've got a GP set though, with, different diameters and curvatures that will apply to infants and toddlers, you should be fine. But you do want to do some sort of diagnostic lens fitting because empirical fitting is a little bit difficult with infants since we're not going to be getting the greatest data from any sort of diagnostic equipment. You do want to have fluorescein strips in office when you're doing your diagnostic lens fitting, and everything is done outside the slit lamp, which is kind of nice. You're not having to put anyone in and out. So I'd recommend having a Burton lamp or one of those blue lights that you can just shine a light onto the child's eye to take a look really quickly for bubbles, take a look at the fitting. And, if you're dealing with like 1 or 2 year olds, a lot of times they find that to be really cool. You can give them a mirror and say, okay, let's look at your eyes. They're going to be green. And they're like, whoa, so everything's out of the slit lamp and that helps you move quickly as well. You'll want to have loose lenses or some sort of ret bar when you're doing retinoscopy over. You can't put, again, infants and small children behind the phoropter. You won't get good data. And you got to be moving quickly. And you want to, have them in open space, help make sure that you're doing some control of their accommodation. And I always recommend having some sort of toys that have noise or some sort of child movie on your digital screen so that you can distract them. A lot of times in the beginning, patients come with 2 parents. And so it's nice because, the child's comfortable with both parents. One of them can be the distractor for me while I'm doing retinoscopy, and the other parent can hold the child in the exam chair. If only one comes to the appointment, you just got to get creative. I've got pens that have little spinning lights on them, make noises. Some exam rooms will have little toys that you can turn on a shelf just so that there's noise and some sort of distraction to get the child looking somewhere. And it really does help, especially with the fear that comes with it with the toddlers, because it gives them something to kind of focus on and be part of a game with you during the exam. When we're fitting GP lenses, not everybody has this luxury. I happen to work in ophthalmology and I co-manage with a lot of the pediatric ophthalmologists. So sometimes I get lucky in that I have exam information from their exams under anesthesia. And sometimes they'll get corneal measurements for me. Sometimes there'll be keratometry values. And sometimes they'll have some refraction that they did with retinoscopy. But sometimes I won't have any of this information. It really just kind of depends on how their exam went and how much time they had. But I do ask them, if you have a free moment and you could get these measurements for me, if you can try, because they're under anesthesia. Otherwise, I can get all that information when they come in for the exam. And you do want to keep in mind that the corneal measurements might be a little bit different since they're, sleeping in an exam under anesthesia, but it's not going to be significant. You'll still be putting a lens on to take a look at how it's fitting on the eye. So even if it's not exact, it's just a very good starting point. But if you don't have this information or you don't have the luxury to go in with an ophthalmologist to do your own exam under anesthesia, don't think that this is a barrier where you cannot fit pediatric patients in contacts. When we're fitting the GP lenses, I like to touch on the idea of the topical anesthetics. A lot of times you'll read that it's recommended to do, and the other times you'll read that it's not necessary. In my practice, I have not noticed that using topical anesthesia really does any sort of benefit for INR or for the fitting. Usually patients are crying or they're, fussy because of the fear of the experience with the contact lens itself, fear of the unknown. They're a baby, someone's touching their eye. They've already gone through a lot of different surgeries. So it's usually that's making the patient uncomfortable or crying or having fear, and not really the lens awareness. So I feel like if I don't have enough time to have a cooperating patient, I don't want to spend any minutes putting a drop in that will start the fussiness, start the crying. So I try to skip that step. I don't think the lens awareness is really a big issue. But if you have, a 3-year-old, 4-year-old, and you think that it's going to help you get better results and help ease the patient, by all means, put that anesthetic in the eye. Oftentimes the patients that I'm getting, especially for aphakia, are infants, and by the time we get to toddler years, they've already gotten really comfortable. But do what works best for you in your practice, and if topical anesthetics helps, by all means do it. But if you think you've only got, a 2-minute window to get a lens, fluorescein assessment, and retinoscopy, I would skip the anesthetic and just try to distract and move forward with your OR. Diameter of GP lenses, usually it's going to be around 10 millimeters or larger. And the reason why we go a little bit larger than we would for maybe an adult GP lens is that we're trying to prevent lens loss. So if it's a little bit larger, it'll tuck in underneath the lids and prevent it from falling out. But that's going to vary depending on the patient's corneal diameter. So I say roughly around there, but usually it's going to be maybe 1 or 2 millimeters larger than their corneal diameter. The base curve is based off of the infantile aphakia treatment study protocol that I have in here. And you want to start with 1 to 1.5 millimeters steeper than the flattest K reading. Now, if you weren't able to get K readings, do not panic. Know your normal averages for different, and I'll go into this, but the Ks for around roughly age group. If you don't have Ks and you didn't have a way to measure those, don't feel like, oh my gosh, where do I start? You just want to start somewhere that's kind of close in the ballpark on average, and then you can adjust based off of your fluorescein assessment. When you're looking at fluorescein, you want to, like I said, outside the slit lamp, you want to have Burton lamp or blue light for evaluation. You want to take a look and make sure that the lens is well centered and that you've got close to apical alignment, maybe minimal apical clearance, but definitely not significant amount of pulling where you're getting bubbles or something that could lead to dimple veiling down the road. And when you're looking at that edge, you want to make sure you have about a millimeter band 360 on that edge profile. That would be a good fitting lens. And the reason is we don't want to ever have a potential binding moment where that lens is not moving, not providing tear exchange, and binding onto the cornea. So you want to make sure you've got enough edge lift that it's really going to be promoting tear exchange and no binding onto the cornea. Then you want to do your retinoscopy to refine the lens power over your diagnostic lens, and then order with the specified material. And I would recommend doing a high DK or hyper DK material, especially because we're fitting these on children. So a little bit about some facts about congenital cataracts is that it ranges from 1 to 15 out of 10,000 children. And approximately a third of these congenital cataracts are inherited. Some other causes of cataracts are from, in utero drug reactions, also systemic diseases like rubella and measles. Shockingly, I thought that I would never see a cataract from rubella just because of all of the vaccinations that we have, but I did have a patient that came from overseas and she had rubella, and so her child had bilateral cataracts from the child having rubella, and so it's still something that you might see in your chair, and so I wanted to list that on there. And then the final one would be idiopathic, just no underlying cause, but just occurred. And so generally, cataract extraction is usually performed around 6 weeks if it's unilateral, 6 to 8 weeks for bilateral, because we usually leave about a 1 to 2 week window in between each eye. Now, obviously, if the cataract is not detected until later on, then the surgery is going to occur later. But the sooner we can get that cataract out and get a contact lens in their eye to start promoting visual development, the better. IOL implantation is not usually put in until around 2 or 3 years old at the youngest, because the eyes continually grow, the eye's not stable, and if we're putting an IOL in a small infant's eye, you're only increasing the risk of other complications, especially glaucoma. So usually the youngest they'll want to do is around 2 to 3 years old. I did ask this question to one of my pediatric ophthalmologists of what her preference was, because everyone's probably has a little bit of different preference time. And she actually said the longer we can wait, the better. And so what determines the longest that we can wait? It usually comes down to how well we're doing with the contacts. So if a family's struggling with contact lens wear, they're not able to get them in every single day, it's becoming more of a struggle and a nuisance for that family. They're losing lenses all the time. Compliance is really poor. This is probably a family where we're going to do an IOL implant at that 3-year-old age, just because we'd rather be getting vision development than not. And you start to have to weigh out those risks to benefits. But with my pediatric ophthalmologist, she said if we can wait till teenage or adult years, that would be ideal, because that risk factor of developing complications or developing glaucoma goes down the older they are and the more developed the eye is. And so I have several patients that are 10, 11. They're doing great in contact lenses. They're seeing well. They're wearing their overlays, no problem, that we don't even talk about IOL implantation right now because it's not really necessary for them. They're doing amazing, and the families are fine going that way. But then there's other families where, we're talking just like we would for someone like with LASIK who's extendedly abusing their contact lenses, and maybe that's an option. Same kind of idea where if compliance is an issue, we're losing lenses a lot, we start talking about the risk factors of having permanent vision loss related to amblyopia, and they become a good candidate for that IOL implantation sooner. So just as a reminder, contact lenses are fit on infants to restore their vision, and it could be a good option for long term.
Un comprobado líder en la práctica de lentes especiales y ojo seco. Cuando la precisión importa.
When they looked at contact lenses in a study versus IOL correction, just to kind of solidify this concept, pediatric IOLs did not show a significantly more improved visual acuity than contact lenses. So what this says is that contact lens correction is a very good option for patients for vision correction following cataract extraction. Binocularity, however, could be improved by having an IOL versus contact lens because of what we talked about earlier, those magnification differences. So IOLs tend to provide normal vision without huge magnification differences, whereas the contact lenses provide about 8 to 12% magnification difference. So the binocularity factor could be different, but in terms of visual acuity itself, they did not see a huge significant difference between visual acuity improvement with IOLs versus contact lenses. So ultimately, another study in 2003 showed that there really isn't enough evidence to recommend pediatric IOLs at a young age. Contact lenses, if you're doing well, can be continuously recommended, and it can be continuously recommended as a long-term option, like I said, to reduce those risk factors. When we're fitting aphakia, think about typical contact lens powers that you're going to be using are going to be from +20 to +40, depending on the patient and their first year of life. Average contact lens less than 1 year old is around +31. In the first month, they're going to have a lot of changes. In the first 6 months, there's going to be a lot of prescription changes. And so Those are things to keep in mind when you're discussing with the families in terms of follow-up care and importance to come to their follow-ups. Not only is it just to make sure that they're still doing well with the contacts, but it's also important to make sure that we're changing powers accordingly to make sure they're getting the best vision possible. In the first 2 years of life, there might be a 5 to 10 diopter change because as the eyeball continues to grow, the diameter of the cornea is changing, the curvature of the cornea is changing, and the degree of hyperopia is decreasing. So you will see significant changes over the first 2 years of life, big changes within the first 6 months. You want to make sure that you're fitting contact lenses for near in infants because that's where their world is. We don't have infants needing to read far away. Everything is up close. And anything that they're grabbing with their hands, everything's going to be, their world is up near. So that's where we want to make sure we're correcting their contact lenses. So when you are doing your over refraction, whatever number it is that you get, you want to make sure you're adding 3 diopters of near correction to that contact before you dispense it. Now, as the child gets older, we need to make some modifications to those powers. And you'll read a lot of different studies that say, at this year, you should change it by this year you should change it by that. Really, there's no hard and fast rule. You just kind of want to, maybe a rule of thumb is to think about, are we walking or are we not walking? If a child's not walking, having everything up close is perfect because, like I said, their arms are short, their world is up close, everyone's holding them up close, everything that they're touching is up close. So really 3 diopters is fine. But if they're walking, you want to make sure that you're not impairing their ability of depth perception where they're not fearful to step or grab onto things. So that's where we got to bring back the near correction a little bit. And I usually say, tailor at 1.5 diopters. There's no real science to that change. I usually say, you'll see trends with all the patients that you see. And if you did 1 or 1.5, they're still going to do great. If you felt like you didn't do enough, really get the feedback from the parents. How are they responding? Do you feel like they're grabbing onto things? Do you still feel like there's hesitation when they're walking? If parents give you that kind of information, then maybe bring back the near correction a little bit more. But, it's really just an art and kind of what you prefer after you start seeing trends over time. So I usually say if you can think rule of thumb, walking versus not walking, that'll kind of remind you on when it's time to make those changes to the near correction. But by 2 to 3 years old, we're usually tailoring the distance correction in full, so full vision for far away, and using an overlay bifocal for that reading for the patient. Now, when we're doing that bifocal, you want to make sure that you specify polycarb for protection and safety, which, as we know, for everyone under 18, it should already be mandatory, but I always write that down anyways, and I always write segmented bifocal on there. Our opticians know that you should put the bifocal high for an infant, but if you're not sure if they're going to go and take the prescription somewhere else and they may not know that, maybe just write some notes on the bottom of how you want the bifocal to be fit for the patient. And bifocals can be bilateral or unilateral. I think it really depends on the clinician. In my practice, I do unilateral bifocals just because I want to let the phakic eye accommodate freely without any unnecessary blur. I've seen other offices where they do both and the patients do fine as well. So it's really clinician preference. I will say that progressives are a possibility. However, not my preference, but I did work with 2 different pediatric ophthalmologists I do work with 2 different ones at my office, and one of them really prefers progressives and the other one prefers segmented bifocals. And so because I'm in a co-management setting, I do try to tailor a little bit to the doctor's style just so that we're not kind of changing lenses just because of preference of the ophthalmologist. But I usually, if it was me just picking an option, I usually like to do a bifocal because I want to guarantee that the child is looking through the bifocal. And I can't imagine that, a progressive, that they would be getting the full rating all the time just because it's hard to know where to look. But either one is an option for you. And so you'll do what you feel is best in your office and what you prefer. When we're fitting aphakics, I wanted to use an example here on things to think about. So let's say you have an infant that comes in, they're plus 26 with retinoscopy, And so when we vertex that to a contact lens equivalent power, we get 37.75. So if we round that to 38, you've got to add your 3 diopters for the near. So now we're looking at plus 41. Well, that alone already tells you that we're not going to be able to use SilSoft because SilSoft only comes up to plus 32. So our other options will be a GP or some sort of custom hydrogel type of lens. And in both of those categories, I do feel like you have a significant amount of parameter options. However, I personally tend to just go the GP route because I really have had a lot of success with GPs. When you're thinking of base curves, like I was saying, if you don't have access to a keratometer or autorefractor, 47 to 49 is usually around a good K-zone for at birth. And by around age 3 or 4, we're looking at 43 and a half. So around age 3 is normally when we get close to adult parameters. But if you can kind of remember 47 to 49 is a rough average of where a lot of people's corneas are. If you don't have access to Ks and you wanted a starting point, that would be where you'd want to start and throw a lens on the eye and then bracket your diagnostic lens fitting from there. We usually have a lot of flattening in the cornea in the first 6 months, or the most significant changes in the first 6 months. And then we start to kind of flatten out, a plateau on the base curve around 9 months. And then around 3 years old is when we have approaching the corneal curvatures of an adult. For diameter, average corneal diameter is about 10 millimeters at birth. And then you usually get the most changes in corneal diameter in the first year of life. And around age 3, again, you have close to your adult corneal diameter parameters. The exception would be someone that has microphthalmia. But, and just as a reminder, small palpebral fissures, diameter is why we go bigger with those lenses, just to make sure they're tucked up underneath those lenses and lids and try to help prevent that lens loss. With all patients, you want to make sure you're doing a really thorough insertion and removal training. It doesn't have to be you personally. I don't actually do the trainings. I have a technician that does that for me. I've trained her really well on all my expectations and everything I want her to review. And then when the patient comes back for follow-ups, I tend to review those kind of subject matters, make sure that we're on the same page, that we haven't gotten creative in between follow-ups, and that we're still following what was recommended. So at that initial dispense visit, you want to make sure that you're going over insertion and removal for whatever lens you choose. For me, if I'm doing a SilSoft lens, I like to recommend ClearCare, but I also give them a multi-purpose like OptiFree. The reason for that is I like the ClearCare done every night for a really good disinfection, but when they're inserting the lens, sometimes the lens gets dropped somewhere or the patient flicks their mom's arm and the lens goes flying. And I don't want them to panic and say, oh my gosh, it fell on the ground and all I have is ClearCare. So I want them to be able to clean with the multi-purpose really well, get any lint off of that contact lens, really disinfect that lens, and then go back to doing insertion. So I give the recommendation of those two. For a gas perm, you can recommend any sort of GP solution that you want, including ClearCare. But whatever's your preference, I would just keep in mind that there may be some times when the lens is dropped, so make sure it's something that they can do in the moment and not only one option that requires at least 6 hours for cleaning. You want to review lens care and solutions really well. We don't just hand solutions and say, bye, see you later. Our technician opens up the boxes. She goes over which case is used for which solution. We review the importance of throwing away cases as we replace solutions. So a lot of times we use the analogy like a toothbrush, and we want to make sure that they're really cleaning those cases daily and throwing them away when they're getting new solutions, because that's usually one of the biggest risk factors for getting that infection is that the case is really, really gross. So make sure you're reviewing those lens care and solutions at all your follow-ups. It just takes a brief moment, and it's nice to kind of reinforce that each time they come in, just to make sure, like I said, that they didn't pick up habits, they didn't run out of something and then think that they could just use a saline wash as a cleaner. And then also making sure that they're never using water. I don't know how many times I tell patients that, even adult patients, over and over about the water, and then they come back and they've That's the one thing they forgot, that they couldn't use tap water. And so the more you repeat yourself, the more you reinforce, the more likely they're going to follow and be compliant with the care that you're prescribing. I always make sure that the families are able to demonstrate successful insertion and removal in office before leaving with the lens, and always providing a backup pair. You want to make sure that if they do lose a lens, that they're not waiting until 2 months to come back to their follow-up to get that lens. So they always want to have a backup lens with them, which is really important. And if they don't have one and they're down to the last one, always tell them to call in to get that replacement lens so that they always have a backup pair or spare pair with them, so the child's never going uncorrected. I just wanted to insert this URL because I give a printout of that URL for the Boston Children's Hospital video. It's a really good video on how to insert soft lenses or any soft lens for aphakia. It's a little dated, but it's a safe video. Everything she says in there I totally think is okay and safe for patients to view. And I have them watch that on the day that we're going to have them do insertion and removal training, just as a brief overview of what to expect. Then we go through the INR, and then they have that reference video so that if they go home, they forgot something that we said, they could watch this video, and it's kind of a reinforcement of, techniques on how to insert and remove those soft lenses. The mother had multiple children with aphakia, and so she created this video, and Boston Children's Hospital has it posted, and I think it's a really good video. So feel free to take down this video if you do ever want to give something to your patients to be able to reference, so they're not just Googling whatever on the internet, they're actually seeing something that's at least safe methods on insertion and removal. And one last thing is that we always encourage parents to cut their fingernails as short as possible, because we don't ever want them to be getting frustrated and using fingernails as a source of removal of the lens. So we always kind of encourage them, if they have acrylics on, we encourage them to get them removed until they feel really good with insertion removal. And then if they want to go back to acrylics, but I think once they realize it's really difficult to have long nails and deal with contact lenses, they tend to not continue to get acrylics, which I think is a good thing given that you're dealing with a child's eye. And it's a very delicate eye and small. Follow-up schedule, you'll see on the initial dispense, you'll see them back in 1 to 2 weeks. Right now with telemedicine, I've been doing a lot of these just over a video visit, just to kind of review solutions, see how they're doing with insertion removal, and then seeing them back at like a 1 month mark. If you want to see them back the 1-2 weeks though, that's no problem. It's whatever your comfort level is with that. And I guess patient dependent. How did that initial visit go? If you felt like they did okay on insertion removal and you want to witness them do that again in person, you can have them come back in. But usually I've been doing that 1 to 2 week visit on a video visit, and it's been working out great. And then I'll have them come back, at 3 months, check for parameter changes, and you'll be consistently seeing them every 3 to 4 months thereafter. In my scenario, since I'm co-managing always with a pediatric ophthalmologist, we kind of do joint visits where I manage all the contact lens portion. They manage any other aspect that they're looking at, but it's still consistently every 3 months or sooner, depending on the patient, depending on if you feel like something's going wrong. And then they always have our number in case they need to call and schedule sooner. At each one of these follow-up visits, you want to make sure that you're doing an over-refraction, that you're checking the fit on the eye. If it's a soft lens, seeing how it's moving, seeing if it's well-centered, and examining how it's fitting on the eye in general, and removing the lens, and then taking a look at the cornea, taking a look at the limbus, taking a look at everything on the eye, just to make sure that there is, if it's a GP lens, that you're not getting a lot of staining, that it's not creating scratches or dimple veiling. If it's a soft lens, that it's not torn. These are things you want to be paying attention to. And you always want to be asking the parent, are they seeming really light sensitive? Do they rub their eye a lot? Is the eye getting red? Are we seeing mucus discharge? Any habits that are changing with the patient? They're blinking a lot, their eyes watering a lot. These are things that you want to ask at each visit too, just to make sure that there's nothing going wrong. And then again, like I said, reviewing that lens care. So let's get into patient cases. First patient I have here is a patient that was wearing CellSoft. That's what we fit them for. It was a 6-month-old. Presents for a contact lens eval and training in the left eye. They were born premature. They had congenital cataract extraction 4 weeks prior. and they were patching the right eye every 2 hours daily. They presented wearing a CellSoft lens with these parameters. And my pediatric ophthalmologist, she automatically, after she does surgery, puts a lens on the eye. And because it's approved for continuous wear, has them leave the lens in, have them do all their drops on top of the lens, and then they come see me and I make parameter changes and give them a fresh lens. So that's kind of nice that I know that the patient's not going for an extended period of time without correction. If you're in a situation where you're just referred the patient, you're starting from scratch, I would grab a lens that's around a plus 32 if they're around this age, and then do your over-refraction on top and go from there. So exam findings for this patient, as you can see in the photo, the lens was well-centered. It had good movement on blink. The over-refraction I was getting for this patient was about a 2.5. And she did have a lot of depositing on the lens because of the Maxitrol that she was using in the cyclogel. So I replaced that lens in office, but because she had a 2.5 diopter over-refraction, that's about the range we want for near correction. So I didn't need to make any changes to that lens that day in terms of parameters. We went over training, so on insertion, here's some tips on kind of what we discussed with the parents, telling them to, when they're inserting the lens, to use their thumb and forefinger on their dominant hand to partially pinch the contact, kind of like a taco. You want to use your non-dominant hand and your palm to kind of stabilize the forehead and pull on the upper lid. Tuck the lens underneath the top upper lid, and then kind of using your other hand, pull that lower lid down and kind of guide the eye to blink a little bit just to make sure that the lens is nice and well centered. Usually if you get the lens in the eye and you just kind of encourage them to blink, you don't have to do much manipulation at all at that point. And you want to just make sure that everything you're doing is with the pads of your fingers, no fingernails, and try to be gentle, but know that if the baby is crying, they're just scared because you're touching their eye. That's one of the biggest things to convey to parents, is that you're not hurting them. As long as they're not digging fingernails and they're not digging their fingernails in their eyelids or being very aggressive, it's more of just a fear of the experience and not that they're actually hurting them. On removal, you want to use your a two-hand method, using the lids to kind of expel the lens. I usually tell them whatever fingers are comfortable, whether it's your forefingers or your thumbs, but remembering to use pads only and using that pressure towards the eyelid margin to kind of do a scooping motion and get that contact lens out. The advantage of a CellSoft is you got that button to look for, and so putting some pressure towards the button, it pops out very easily. But you want to be using the eyelids to kind of do the manipulation, no fingernails towards the cornea. Moving on to a soft prosthetic contact lens patient, I had a 9-year-old male that presented for a prosthetic lens in the right eye. And this patient had a history of a corneal laceration, an aphakia, status post globe repair. So when they were doing kind of exploration during that surgery, there was a presumed that the crystal lens had been expulsed. And this all occurred because of an arrow. The child was kind of cocking the arrow and it ricocheted back and knocked him in the eye with the knock of the arrow. And that force created this trauma for this 9-year-old. He did have a dense pupillary membrane, and the B scan had showed that there was no retinal detachment. The patient presented to me very, very photophobic. He was light perception in that eye, unfortunately, but still very photophobic given all the trauma that occurred and that corneal scarring, and he had a resolving subconch heme. So the dad reported that he keeps his right eye closed most of the time, and they're worried that it's affecting his left eye. And I think because what they were most concerned with by the left eye was that because he's closing his right eye so much, he was still squinting in the left eye, and they felt that he just wasn't really seeing well altogether because of being so distracted by the photophobia of the right eye. So the goal was to fit him with a prosthetic lens for cosmesis, and also to help with some of that light sensitivity that he was having from the trauma. when we take a look at these photos, these are the initial injury. And on the right side, you can see following the surgery with the sutures in place. But it was really unfortunate. He's so young that this occurred, but it just kind of keeps in mind that even something that we consider a toy can cause severe trauma to the eye. When he came to his contact lens eval appointment, this is what he looked like. So he had, that resolving subconcheme there, and also kind of a corneal hemorrhage as well. It's hard to see the subconcheme, it's over in the corner, but you can see that hemorrhaging centrally in that corneal area where the surgery occurred. I tried to take a picture of him with his eyes open. I just told him, relax your eyes, but you can see he's really having to force his eyes open. That's how photosensitive he is. You can see that he's using those forehead muscles to really try to open his eye. And because of that, he's so concentrated. I think that's what the family meant, that they felt like it was affecting his left eye. So I trialed a few prosthetic contact lenses. I have a few different fit sets in office. One of them that I tried was the Cantor. And in that set, number 2 was the best match for him. It had a black back on it, open pupil. Dad wanted him to still get light perception through, but he did consider me ordering a secondary lens that was pupil occluded for like pictures so that it would look a little bit more normal compared to the left eye. But they did want him to get light perception, so we did open pupils at this fitting. And I also had trialed an Adventure in Colors lens, which is a hand-painted lens versus the computer-printed with the Cantor. And that Adventure in Colors lens was good. It was just a little bit darker in appearance in the left eye. And the more we started talking about costs between a hand-painted and a computer prosthetic, the dad decided for now they wanted to at least get started with contacts and see how it goes. And if it went well, then they would consider a hand-painted one that may be a little bit more customized and match a little bit better. So this is a photo I took, so you can see this is with the Cantor number 2 lens with the open pupil, and it's a pretty good color match. I thought it looked great on the eye. I had him look off to the side when I took this picture just so that he wouldn't have to be forcing his eyes open so that we could really get a look at the prosthetic contact. So he doesn't actually have like a left gaze deviation. It was just I was having him look that way because I thought it would maybe relax him a little bit so he wasn't looking straight at the light. But you can see it's a good match. You can see the white coming through because of the cornea. So if we did decide to do a black pupil in the center, that would look a little bit more like the left eye. And Dad was saying maybe for like family photos or things where they wanted it to look more uniform between the 2 eyes, that they would consider getting a lens like that. And this kind of just reviews that, but kind of what I just mentioned about down the road, they might do a hand-painted lens. So the next case is an option for you with your high myopic patients. So this is an 8-year-old female. She presents for contact lens eval. She has history of intermittent exotropia and a little bit of amblyopia in the right eye. But you can see how severe her prescription is at 8 years old. So a minus 1850 plus 1 at 142 and a minus 1525 plus 175 at 50 in the left eye. Because of her prescription and because of the astigmatism, I was automatically set with, I thought the best option for her oxygen-wise, vision-wise would be a GP. So we talked about that. Based off of her case, I selected some lenses, threw some diagnostic lenses on, and I felt that, at that initial visit, she was seen pretty well. I did a very few different, maybe 1 or 2 follow-ups where I did a little bit of changes there. But you can see this is the final lens parameters that we ended up with. And with this prescription, now a year later, she's actually seeing 20/20 in both eyes. She's about 20/20 minus 3 in the right eye, but 20/20 in the left. So this just shows that with glasses, she was demonstrating a little bit of amblyopia in that right eye. But after wearing contacts for about 6 months to a year, she's actually equal vision in both eyes, 20/20. So those contacts made a huge difference for her in terms of optical quality, magnification differences, and now she's seeing equal acuity in both eyes. And this is what these lenses looked like on her eyes. So They were fitting well, a little bit lid attached, good edge clearance there. And I took these pictures just using my iPhone dock on the slit lamp so I wouldn't have to move her in and out of the room, and thought those looked great and they're fitting well and she's comfortable. So our next patient case is a patient that was wearing a GP for corneal transplant. And as you can see, this patient was a 7-month-old that was referred to me for a contact lens eval. So we're talking very young. Little background on her history. She had bilateral corneal opacities. They thought she likely has Peters anomaly or some severe anterior segment type of condition. She had had a transplant in the right eye that failed, and she had a transplant in the left eye with some epithelial irregularity. She was using Pred Forte in both eyes, Polytrim in both eyes, and she had a tube shunt in her eye as well. So we're dealing with a glaucoma patient as well as corneal transplants. Very, very involved case. And because she had that transplant, I automatically said, I need to fit her in something for a corneal transplant, which would be ideally a GP lens. So you can see at this initial contact lens eval, this is what the 7-month-old's eyes look like. And that right eye, how that transplant failed. But the left eye, we've got a good button of clear vision. Surrounding tissue is opaque, but in the central area, good clear graft. And just a little bit about Peters anomaly, because we don't see this all the time. So if you weren't familiar with what Peters anomaly is, it's an incomplete formation of the anterior segment, leading to incomplete separation of the cornea from the iris or lens. It's usually bilateral, and the cornea is going to be cloudy, which leads to that blurry vision. This is why we need to address this early as well, because if the cornea is completely opaque, we're not getting good visual input, so vision development can be impaired. The density of the opacity can vary patient to patient, and the amount of cloudiness and the location of the cloudiness can vary patient to patient. Sometimes it's just off to the side, and sometimes it's complete cornea, so each patient's a little bit different. Nearly 50% of individuals affected are going to have low vision in early life, and about 25% are legally blind. So it's often associated with glaucoma, cataract, and microphthalmia. So these are all things to kind of keep in mind as we go through her case. The first lens I ordered after fitting her, these were the parameters. I fit her in a post-PK oxyflow lens. I obviously needed to make modifications on the size and parameters given her cornea, but the biggest issue I was struggling with in the beginning was cooperation. So I didn't have Ks from an examiner anesthesia, and I wasn't dealing with a typical cornea. It was a graft patient, so I did have to do a pretty good diagnostic fitting, which was really difficult because she wasn't cooperative, and the parents were very, very nervous with the whole process. So it was a little difficult in the beginning, I will say that, but definitely possible. So with the first lens on there, the biggest thing I was getting was central bearing. So when I ordered, I had to kind of guesstimate the degree of which I was going to steepen the lens, just because I knew I wasn't going to be able to get 2 or 3 or 4 lenses in the eye at a given visit. It really was like one lens, one look, 1 over refraction, and then kind of assess from there, given the cooperation. This is not the case with all of my patients. It just, in her case, I think she had gone through so many surgeries, so young. Parents were really concerned, and so it was a little difficult in the beginning. One of the things we ended up doing to help mom with insertion was she wanted to make sure the lens was darker. So we made it gray instead of a blue or a green, because the blue or green was a little too translucent for her. And even now they still like it to be gray, and so we made it dark gray. But with my follow-up appointments, the main thing that I was changing was related to the curve, the base curve. Because when she'd come back, there would still be a little bit of bearing, and so I needed to make some more adjustments. But eventually, I got to a lens. You can see my initial one. I started with 738 base curve. Her final lens that we ended with was a 677. So I had to make a good transition on the steepness over time, but she's doing great. And fast forward to now, I just recently saw her. Her visual acuity, I can finally take it, because before it was just kind of, all objective measures, but this time we were able to take it, and she was 2150 with Allen Pictures, which I was very excited for her. And she's very talkative now. Her personality's completely changed, from being scared to like coming to these appointments, and she actually has fun. She's very cooperative. She's my helper, and always a great time seeing her. And this time she was very excited because I told her, "You're going to be famous, okay? We're going to take some pictures so that you can be famous." And she's like, "Can I look at my pictures?" So I thought it was, it's great to follow these children from when they're a baby to now she's 4 years old. So this is that photo, and you can see that corneal GP on there. It was difficult for me to get a photo with the fluorescein in the dark. I couldn't get a very great photo. It was difficult that day, but I did with the light, and you can see it's doing great. And I was trying to elicit to you the centration there and kind of the size of her overall eye. But she does wear overlay protective glasses. Now, she is phakic in her eye. The reason we have that bifocal for her is because of the low vision aspect that she'll have. We just wanted to magnify things for up close with her a little bit because of that vision. But she's doing great. She loves wearing her glasses. She loves wearing her contacts. She loves coming to the eye doctor. Last patient case for today. It's an 8-year-old female referred for scleral contact lens evaluation. This patient had Stevens-Johnson syndrome, and they're not sure if it was from taking ibuprofen or if she maybe had a herpes simplex virus type of reaction, but she had undergone 2 amniotic membrane treatments and before coming to see me. And she also had trichitis that they were treating with epilations at follow-up visits. So when she came to me, she was using artificial tears 4 times a day and Sustain ointment. And the biggest complaint was she was having photosensitivity, red eyes, and not being able to open her eyes at all throughout the day. She came in with her eyes completely closed. Her parents mentioned that at school they had accommodations for her where she was in the back of the classroom in the dark in her own little cubicle, which sounded really isolating for someone at 8 years old to have to be undergoing in school, and that she was just having a really hard time tolerating day-to-day activities. So that day, her entering acuity was 2150, left eye was 2100, and I fit her in a 15.4 millimeter scleral lens. Reason why was she was a child, and I wanted them to be successful to get the lens in the eye, but also it was very difficult because she couldn't really open her eyes. Even when I numbed her with proparacaine to get these lenses on, very, very apprehensive, very difficult. So if I was having a hard time getting the lenses in, I could only imagine how often the parents were going to actually be able to do this. So I figured I'd go with slightly scleral lens, but slightly smaller than maybe we could have done to make sure that they were successful. We can always down the road go bigger and refit to larger lenses, but I want to make sure they were successful and they were getting the lens on the eye and that we were at least getting some therapeutic option versus nothing. And so when I did her over refraction, you could see even with the sclerals on, it was still 20/80. And that was just because of the degree of, surface SPK, irritation. She could hardly keep her eyes open even to do the visual acuity. The fit itself was looking okay, but the edges were a little bit tight. So throughout the process of the follow-ups, the main thing that was being changed was changing the OR as needed based off of whether the vision was changing, and then also making sure that edge alignment was a little bit better. She ended up with toric peripheral curves and then made modifications based on the follow-up visits. With scleral lenses, there's so many different cleaners and there's so many different saline options. We couldn't say this that long ago that there were this many options, but now we're really fortunate to have so many options out there. I'm just waiting for the day when they can find them over the counter. But with her, because of the size and for simplicity to just do a one-step system, I recommended for her ClearCare because that's safe for GP lenses, and then there wasn't too much involved for the parents to think about. And she was filling the lenses with scleral fill. After 3 months of wearing the scleral lenses, she had very good comfort. Parents reported that they could see a difference in her personality, a difference in the way she carried herself day to day. She seemed happier. She was able to keep her eyes open more. Did not have any complaints of photophobia. They did not have to do those special accommodations at school anymore. She was not sitting in the dark in the corner. And you can see the vast improvement in her visual acuity. 20/20 in the right eye and left eye, -2. And she was still doing the preservative-free artificial tears 4 times a day in both eyes. I switched her over to genteel gel at night just because they had a complaint that they didn't really like the ointment. It was making her vision blurry and goopy. So once they tried the genteel gel, they liked it a lot better. But you can see how the scleral lenses made a huge difference. And a lot of times we wouldn't think about this for an 8-year-old as being an option, but given her condition, Steven Johnson, we needed to do something that was therapeutic and that was going to cover a lot of the eye. And even though it was a really difficult fit in the beginning, encouraging the patient, encouraging the parents, reviewing, I think she reviewed lens insertion and removal with my technician 3 times. And we always encourage them, if the first time you don't feel good and you need to come back a second time or a third time, you are more than welcome to come back as many times. Just schedule with the technician and get all the help that you need, because we want you to be successful and we want you to wear the lenses. And you can see how significant this has impacted her life. She's now 11 years old and has been wearing them for 3 years. Eventually, we'll probably go a little bit bigger to cover some of the surface area of her eye. But this is what the lenses look on her eyes. So you can see it's nice uniform clearance through there. She doesn't have any corneal irregularity that we're vaulting over. So we just need enough clearance to kind of cover the cornea. But you can see on the edges, she still has some redness there. And that's just from, being exposed to those areas. So over time, I think what we'll do is we'll eventually go a little bit bigger just to cover a little bit more of those exposed areas and hopefully help with some of that dryness. But it's night and day difference for her. So it's been amazing. And that is all I have for today. But thank you so much for having me. I hope that learning a little bit more about applications for pediatric contacts in your office and how it is possible and it is not as difficult as we all think or as time consuming as we all think. Hopefully you'll be able to incorporate some of these lenses in your office. Thank you so much. Have a great evening.